What's up, everybody? I am so excited. Y'all know I always get excited when Dr. Mario decides to come and be a guest presenter. Let's be honest with everybody. He's my favorite, like my all-time favorite, even more so than my brother from another mother. Hey, Evan.
Hey, good to see ya.
So I just want to say, for those of you who do not know who Dr. Mario is, I have to ask, where have you been? Because he has been helping to train doctors and staff all over the country in chiropractic for over 20 years. He graduated from Palmer. He also won the President's Award from the Illinois Chiropractic Society in 1998 and 2003 because he's kind of amazing. But it's his education and the time that he spends learning about anything and everything, especially when it comes to coding, documentation, and compliance, which just makes him the go-to guy for us at ChiroHealthUSA. We love him so much, and we love to challenge his brain from time to time with some of the crazy questions that we have, although I don't know that we've actually really challenged you in a long time. So feel free to throw out some crazy questions. Challenge Dr. Mario. And so I couldn't think of anybody better to round out the education on E&M 2021 guidelines better than Dr. Mario. So Dr. Mario, take it away.
Thank you, everybody, and thanks, Christy, and thank you, ChiroHealthUSA, for having me here. This class is a unique class. This is the first time I ever taught this class, so you get to hear it from the horse's mouth here right off the bat. And thank you for that introduction there, Christy. And if you don't know me, I'm a chiropractor. I did just happen to, I say retire, but I went to Plan B. I transitioned, and I'm teaching full-time and consulting and living here in Arizona now, so enjoying the fine weather that Arizona can brag about at this time of the year. If you don't know me, and thanks for that introduction. I didn't write that introduction, but thanks, Christy. But I've been around. I teach for ChiroHealthUSA, Foot Levelers, NCMIC, and looks like June, I'm going to be back on the road after teaching through Zoom for the last year now. And so I am certified in a lot of different things. Just I'm a geek that way, but also on the Medicare Advisory Committee. And as I said, this class right here, I'm bringing you up to date on a lot of it's not just the guidelines, but how to use them properly. And, I've taken courses through the American Academy of Professional Coders, AAPC, and the AMA, and none of it is chiropractic, of course. And so, I got to take that liquid and pour it through the chiropractic filter and see what we have here. So, as we get further into the guidelines, it's not that the guidelines are going to go away, because they're not. But as sure as the sun is going to rise tomorrow, the guidelines will be here for some time to come. It's the interpretation of the guidelines that will change. And so I highly, highly recommend that you stay up to date. And if you're not on my blog site already, it's not your normal Facebook site, but facebook.com/AskMario. Just do it. I don't get your email. There's no spamming and anything like that here. Basically, all you got to do is like me, and then go in the settings wheel, put me in your notifications, so that when I post something, I don't post junk. When I post something, it will come to you, and so you're up to date on everything, okay? I've got a lot of information to go through, but, keep in mind that the E&M guidelines that we're talking about here, I actually am doing a 2 or 3 hour course now on all the applications of the guidelines and everything else. So, just get your caffeine and Starbucks or whatever here. I'm going to go through it. So I'm not sure, but usually ChiroHealthUSA have these webinars archived, so you can rewatch that and take notes as well. But keep in mind that this here is kind of a synopsis, of my book, and I call it a 36,000 foot view of this book right here, which is my book, which is it's a runaway bestseller. So anyway, if you don't have that book, I wrote it. It's there to help you. But before you run off buying it there, I'll give you even a promo code for this group here that you guys can use and save some money and free shipping and everything, okay? So I always, first of all, recommend that you have a pad of paper like I do always here to take notes, and so a pen and paper, and that way, if I say something that kind of rings, in your mind, like, oh, I should remember that, write it down, because you're going to forget 90% of what I teach you in this 1 hour webinar here. Okay, so let's just jump into this and let's talk about it here. When you think about the guidelines for examination, and as doctors, we learn these guidelines early on at school, but I graduated since 1995, before 1995, and they came out in 1992. They first established these guidelines for all doctors. Now, they didn't have chiropractors in mind, but it was all doctors, quote unquote, okay? And they came out with these guidelines in 95, and those guidelines were what us doctors, what we learned. And, we look in the ears, look in the nose, look in the eyes, but, listen to the heart. But how often do we really do that? And that's more, if you're in functional medicine, you're probably using the 1995 guidelines. But the prima donnas of the medical world, at least that's what my medical patients tell me, are the cardiologists. And I could just hear a cardiologist saying, what? I don't study the anus, and so they said, I look at the heart and how it affects the whole body. Well, as chiropractors, we typically look at the nervous system and how it affects the whole body. And those are considered 1997 guidelines, okay? So those guidelines, everybody could choose 95 or 97, and your doctor is kind of like, well, I've got to do certain things. I got to document certain things in order to satisfy the guidelines. And it was like, why? Why are you writing this just to satisfy a CPT code? Do what you're supposed to do. And so that's why, it took 20 some years now to get the new guidelines 2021. Are they going to have further guidelines after this? I really do not. I've never heard any of that. Everyone says this is it, and we're just going to get used to it here. So the key is the guidelines were really to reduce the administrative burden, which means now 1995 and 97 guidelines, those have been put in the Smithsonian Institute. Okay, their history. All right, they're next to the Rosetta Stone. All right, this is what we used to do. Everybody now, as of January 1st, 2021, has to do the 2021 guidelines here, okay? And so auditing and everything else will always be, for these notes generated since January 1st, 2021, will always be utilizing the 2021 guidelines, okay? So, keep in mind that, as I said, what the doctor, and I realize there's staff on here, and so you got to go back and train your doctor, okay, if they're not in on this call. And that's what this whole class is about here, is how to train your doctor. So number one, doctor, do what's necessary. Don't be lazy about it, because it is partially risk management, but what's medically necessary? All right, we listen to a patient and we get an idea of what's wrong with that patient. That's called a differential diagnosis. It's like, give me a list of possibilities. Okay, now examine that patient and do follow-up questions and everything else that is going to better clarify the condition the patient has here, okay? And so that's why the doctor, in fact, and write this down here, this is kind of a cool point here, the doctor orders an exam. Even if the doctor does the exam themselves, which is typical, but it's kind of like, after listening to the patient, Are you going to accept the patient as a patient of yours? Yes. Okay. Now what are you going to do? I think at this point here, we need to do a reevaluation, you see? And so that goes into the thought pattern, which is going to become very important in our talk here, okay? Now, I actually had a doctor just this morning, as a matter of fact, that said, well, you know, Medicare, and this is not a Medicare class, but the doctor said Medicare doesn't pay for an exam. And so therefore, I know I'm supposed to do one and it's mandatory. So can I bill it as just an elective wellness visit because I have to do an exam? And I told the doctor, it's not that you have to do an exam, it's the standard of care that you do an exam. In fact, if you don't do an exam, then you may you may expose yourself, risk management, to negligence or malpractice charges here. Because the standard of care, which is defined as the type and level of care an ordinary prudent healthcare professional with the same training and experience would provide under similar circumstances in our community. In other words, doctor, isn't it that in your training that you do a consultation of, let's say, a new patient or a patient with a new condition, and then you examine them to arrive at a diagnosis and treatment plan? Well, yes. Please show where you did an exam. Oh, I didn't. Oh, and maybe if you did an exam, you would have caught the cancer that the patient had in their bones, okay? And all of a sudden, that doctor's working at Home Depot. So we are not responsible for the insurance the patient has, okay? Everyone repeat that. We are not responsible for the insurance the patient has, all right? So if their insurance doesn't cover an exam, then they pay for it. I have to do that. That gives me, and you know, the rationale is there because it gives me a proper way. I mean, my exams are good, and when I'm done, I know what's going on with the patient here. And it doesn't matter if they have Blue Cross or Medicare or even cash. And that's why even the cash patient, the standard of care is you do an exam. Now, you know, just to, you know, think about this here, we chiropractors, our problem, in my opinion, is that we are too kind-hearted. You know, DC stands for Dr. Creativity. You know, well, if I code it this way, maybe they'll pay for it or maybe they won't. And MD stands for more dollars, okay? Do what's necessary, code and charge for what you do. And if the insurance doesn't cover it, the patient's responsible for it, period. And we all know, in staff, I see you out there, you're nodding your head yes, the most dangerous time for any doctor is when they go to the front desk. It's like, get out of my wife always told me, you got 10 seconds in the front desk, then you get out. Because, you know, it's like, oh, don't just waive the charges for them. No, you know, that's where we get in trouble because we're so kind-hearted, okay? And so, you know, the bottom line is what's medically necessary, that's what you do, and, you know, and you bill the appropriate level of the E&M. And so when the patient says, how much does it cost, you don't want to imply a contract. You're always going to say, according to your insurance carrier. Everyone, that's a quote. That's your script. According to your insurance carrier, Medicare requires an exam, but they won't pay for it. Okay. And then doctors try to do, you know, fancy deals here, you know, but your fee is your fee. And I always tell patients, you know, I said, have you heard of ChiroHealthUSA? No, I haven't. Well, our office has been accredited, which we are, for ChiroHealthUSA. And I have to charge you the same fee, whether you have full insurance coverage, like with a car accident, or none. All right. And so therefore, if you wish, you know, ChiroHealthUSA is a medical discount plan. And if you purchase it, you and any dependents you have, even that son living in the basement there, is covered under ChiroHealthUSA. And in our office, you get this type of discount, okay? And so, you know, time of service discount, which I look at ChiroHealthUSA as a form of discount plan, time of service discount, the government says no more than 15%. And if you're doing more than 15%, it may be an inducement, which is an anti-kickback statute violation. So the key is, if you have those druthers, is the word that comes to mind. It's kind of like the conflict inside you and your doctor. Charge the patient or not. Yes, you charge them. You document that you did the exam. It's medically necessary. And, if you feel you want to give your patients who have high deductibles or deficient insurances a break, well, then do a legal break through ChiroHealthUSA. Okay, call them up. Okay, if you call them up and you go on ChiroHealthUSA, I don't get any, I have no financial gain here. I'm just telling you, in my office, which I still, work with them on a daily basis, we've got probably a good, at least 400 people on that. Patients love it. And I will tell you, when I tell them the discount they're going to get, they say, what's to think about? Let's do it. Okay. All right. Okay. So the key is, do what's necessary. Now, my kids, they went to college, and my house was partially paid for through documentation, because documentation is what I teach, and doctors don't want to hear it. Okay. And maybe, if your staff here, your doctor is kind of like, the doctor doesn't even want to hear about it. So it's kind of like, okay, how do we train the doctor? Okay. Well, one way we can do that is just tell them, number one, you're not fooling anybody by adding in and clicking in all these things here. Okay. With electronic health records, I see these orthopedic tests, and instead of just saying Cosen's test positive right, it will describe how the Cosen's test is done. Okay. Everyone listen to me. Who cares? All right. Nobody cares. A peer reviewer or anyone else, they already know what a Cosen's test is. All right. You're just making that note bigger here. So the key is, you should have policies and procedures in your compliance manual. Remember, it's required that you have a HIPAA manual and a corporate compliance manual. If you don't have one, askmario.com. You'll see some resources there. Okay. It's mandatory. Okay. So, if you do the right thing here, number one, your patients will get well. But number two is, you're going to be able to sleep at night and not worried when an audit occurs. And it's not if an audit's going to occur, it's when an audit occurs. Okay. And I don't do peer review. Okay. I always work for the doctor. I actually, next month, I'm going to court, on a case here where, they're asking for a repayment of $300,000 from the doctor. And it's not like he's got some huge big practice here. It's because they went back several years because his notes sucked. Okay. And the key is, that's what saves you here. So therefore, the last bullet here, doctors, staff, and outside consultants, which, yes, I'm one. Okay. You should, periodically review the doctor's notes to see if you're hitting all the points that you're supposed to hit. Okay. And that's what I do. It's hobby time for me. Doctors send me my notes. It's a service I do, but it's very reasonable. And then I'll send you back a report, and we can talk over the phone, and I can tell you how to make your notes stronger. Okay. All right. So, the key is, again, is don't put it into the note just because it has to be done. So now, okay, when you're telling your doctor, okay, it's that garbage in, garbage out. We call it note bloat. I love that term there. Okay, just do what's necessary. Do the consultation and the exam based on what the patient tells you. Okay, and this here says it all. The history yields the examination, which then yields your diagnosis, then the rationale for treatment, and then your treatment plan. Okay, this is where it's all at right there. Take a picture of it here. If you satisfy all of those things here, they say, okay, the care was medically necessary. If one puzzle piece of the picture is missing, they'll go, what's going on here? This doesn't make sense. Okay, and that includes in your diagnosis here. you do a high level, like a level 4, a 99204 exam, and then you tell me it's cervicalgia or lumbalgia. All right, go see a therapist. All right, cervicalgia is pain in the neck. That's my next door neighbor. I don't get a reimbursement check. All right, I always tell doctors, don't diagnose the patient with a diagnosis you would not tell them in report of findings. You would never sit down with them and say, after talking with you, and I've been in practice 34 years now, and examining you, you have back pain. It's like, what? Well, that's what lumbalgia is. Okay, or muscle pain, myalgia. Okay, whatever. Just give me a break. Okay, So the key is, number one, do what's medically necessary. Number two, what's the status of the patient? State the status of the patient if you're keeping a list. Okay, medically necessary. Number two, status of the patient. Are they a new patient or an established patient? Because that depends on the codes. Now, you'll see here, we used to have for a new patient, 99201 to 205, and then for an established patient, 211 to 215, but they got rid of the level 1 99201 code completely. So in your list that we're keeping here, okay, 99201, delete it. Okay, and the doctor said, well, can I still use it if I want to? No, it's gone. Okay, and so the key is that code is gone. But to determine if a patient is called a new patient or an established patient, has that patient ever been in your office before? Okay, or if you're a group, has that patient seen any doctors in your group before? Yes or no? If it's in the last 3 years, then that's an established patient. The cutoff is 3 years. So anytime they've never been in, or the patient was in, beyond 3 years, that's considered a new patient. If it was 2 years, 11 months, and 21 days, it's still an established patient. If before they were cash and now they're in a new auto accident, it's still an established patient. And yeah, at the beginning of an auto accident, you're going to have to charge those level, 99211 to 215 codes. Okay. And I'll, just tell you right now, your level 1, when I say level 1, that's 99201, or for an established patient, 99211. I would just tell you, between you and I, it's not a hard, fast rule, but it is, you're not going to ever use a level 1 exam. Okay. It's like, even the AMA said, it's like doing a nasal swab for COVID. That's a level 1 exam by the nurse. Okay, doctors are not made. That code 99211. It says in it does not require the presence of the physician. Okay, so charge for what you're worth here, and I'll teach you how to charge those things here. So I gave you a little flow chart here, and so again, ask yourself: have they ever been seen in your office before? Yes. Exact same specialty. If it's within. If they have been seen in the last 3 years, then it's an established patient. If not, it's a new patient here, okay? So hopefully that makes sense, okay? Now, this is what we used to work on before, with the key components were the history exam, medical decision making. Time, maybe if you're doing counseling, but no, not really that much now. Well, now with the 2021 guidelines, it's clear cut. It's medical decision making or time. And I will tell you right now, most likely you don't want to use time. Hear me good, okay? Hear me right. You probably do not want to use time, and I'll explain that here. So again, first of all, document what you do and do what's medically necessary, okay? The amount of history or the number of elements, the content of the history should be medically necessary, but the amount that you have there is not what drives the code here, okay? It's not a factor here. So it's not like you got to check certain symptoms and systems and things like that here, okay? So just do what's necessary here. And then for the exam, it's very important that what the doctor does on the day of the encounter, not the day before, not the day after, or 3 days after, it's on the day of the encounter. That's what counts there, okay? So MDM or time, this is your choice. But I'm just telling you, you can choose either one, but believe me, hear me now, believe me later, you're going to want to do MDM, okay? Medical decision making, okay? And we'll explain all that here, okay? All right. So, the way we do things in the office here, think about this here. Our reimbursement's going down, and I just had this conversation with a doctor yesterday. And I said, doctor, your job is to examine the patient, come up with a diagnosis, and give me a treatment plan, and then do the manipulation. Okay? Anything else outside of that, if you can delegate it, do it. If you got staff, do it. Because the day of the full waiting rooms, reception rooms, those are gone with, COVID. And everybody, do we still have to wear a mask? They're actually predicting another surge, starting around Easter because of these mutation, the variants. So yeah, doctor wear a mask, patient wear a mask, and staff wear a mask here, okay? So anything you can do to cut down time for the patient in your office, then do it, okay? Become more efficient. We tried the drive-through lane, but I can do the neck through the drive-through, but that pelvis was a problem, so we canned that, okay? I'm just kidding, okay? So the key here is you have to adapt, just like cactus, adapt. Everything is blooming here in Arizona, okay? So the staff, when they bring the patient back, they can update certain information and their pain levels as an example. Now, this is like a daily encounter. And so if you're doing a 98941, update the pain levels, zeros, no pain, tender, and agony for each different area, but also make sure that write down, like, is it dull or sharp or whichever. Okay. All right. Now, the staff can collect information as well. And nowadays, we have, you can do like this Zoom meetings here, but you know what? It's simple just to do it over the phone. All right. So the key is you can do it over the phone and get certain information before the patient ever comes in for consults here. Okay. And so again, train your staff and use technology whenever you can. I know some doctors don't even have electronic health records yet, which you should consider that, but at least you have a telephone. And what we do is we make 2 appointments, so you are scheduled tomorrow with Jenna, and she will get your preliminary information. Patients are used to that. If you're going to have surgery, they call you the day before to verify your med list and everything else, right? So do that for the doctor. All right. And then you have an appointment with the doctor. Well, the doctor doesn't have to go over everything with the patient. Literally does not have to. But the doctor must state, and this is another thing in your list here, doctor has to verify that they have read all the information gathered by the staff. Okay. Doctor must verify that they have read. And if you have EHR, just have a macro. I have reviewed the above information. Okay. Now our doctors, they will go in the room and say, so my name is Dr. Mario Fucinari. I understand you have back pain, and it happened about 2 weeks ago, did you say, when you were burying a body in the backyard? Oh yeah, I understand that. Was that the first body you buried, or have there been other instances of back pain from, burials here? Okay, I'm just kidding. Okay. But the key is the patient knows that the doctor knows their history. Okay. Now, here's another great thing here. Okay. Any reports the patient has. I always say patients come to us with baggage. Okay. We're the last resort clinic. So they've already had imaging, whether it be X-ray or MRI or CT, lab work sometime, whatever. When the staff first makes their appointment, ask them, have you had any imaging such as X-ray, MRI, or CT done in the past? Not in the last year, done in the past. And if the patient says yes, okay, now, number one, the doctor can, the patient can send for those, but we always have the patient be an advocate. Call the hospital wherever you had those x-rays done and have the report sent to us. Our fax number is, okay? If you can get a copy of the disc for static x-rays, bring it in with you. Now, when the patient brings it in on the day of the exam, now reading over those things that the doctor will do will go into the examination charges, okay? And I'll explain how that works, okay? So that's why you don't want to get those past reports even the next day, because it has to be on the day of the encounter, okay? And that all goes to what we call medical decision making. Medical decision making is, it's getting paid to think for the doctor. Okay, so when you're explaining it to the doctor, medical decision making consists of this, 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 and the doctor goes, what the heck are you talking about? Just say, you know what? You get paid to think. And the doctor goes, really? Cool. All right, let's do it. Okay, and you're done. All right, just give them the basics there. Okay, and make sure you're updating about COVID, and then you get the history. Chief complaint is paramount. Okay, so staff or doctor, but the doctor doesn't have to repeat it if the staff already did it. We used to have patients come in and they'd be in our office about 45 minutes to an hour for a new patient. Now they're down to maybe 20 to 30 minutes. Okay, and I keep tasering our doctors here. It's like 20 minutes, Peter. Okay, all right, quit that talking about the weather. Okay, but the PFSH, past family social history, review of systems, even all that can be gathered by your staff. Train the staff. Okay, if you're the person, staff person that's going to call the patient, always follow through. It's like low back pain, but patients don't fill out forms properly. You know that. All right. Even for family history, they write NA because they were hatched apparently and don't have a family. So you ask them, mother, father, brother, sister, grandparents, both sides, do you have any rheumatoid arthritis, any cancer, heart disease, diabetes, or MS? In your review of systems, you're going to ask them, are you having any shortness of breath? Why? Because especially for a female, heart problems will manifest as upper thoracic pain. Musculoskeletal problems, and the largest organ of the body is the skin. So yeah, any abnormal rashes or discolorations, loss of hair, redness, trophic changes, we call this here, okay? And then you do the HPI, history of present illness. And one way, if you're calling to ask the patient about the consultation, just think LMNOPQRST. L stands for location. M is modifying factors or mechanism of injury. There doesn't have to be a mechanism of injury, but modifying factors would be like they're sleeping on the, in the recliner for the last month because of their back pain. Any numbness, when did it occur? Always try to give them a date. What makes it better? What makes it worse? Provoking and palliative, prior interventions, medications. Quality of pain, is it sharp, is it dull, is it stiff? That tells us where the pain, the origin of the tissue origin, where the pain's coming from. Okay, is it radiating down? Is it, when I did consultations, I would say, so it's in your foot. I said, you probably haven't even thought about this, but just picture your pain in your foot right now. Is it more on top of the foot or the bottom of the foot? Top of the foot. Is it more in the big toe or the little toe? Big toe. L5. You see, 90% of the diagnosis comes out of the patient's mouth. If you ask the pertinent questions, you got it. Well, then it makes your doctor more efficient. You see? And you want to keep the doctor busy here and not just, rehashing everything else that staff can help them with, okay? In the daily SOAP note here, okay, we, subjective, objective assessment and plan for SOAP, all right? So, what's going on, that's your subjective. What did you do? That's your objective. What did you think? Well, that is actually your medical decision making. So when I talk about medical decision making the rest of our hour here, think about that on a daily basis. We don't charge for an exam, but that's where in the assessment, you have to give me the medical decision making. You being the doctor should note their medical decision making in the assessment, which means it's not just the diagnosis repeated 58 times. Okay, it's not just patient is improved. In fact, I tell doctors that in the assessment, give me your professional judgment of how the case is going on. And in fact, the template, if you will, okay, write this down, the template, how is a patient improved and why do they still need care? If you do that for every region, and yes, every day that the patient comes in for a treatment, you'll be fine. Patient is improved with decreased leg pain and decreased edema, but still has spasms and subluxation of the right SI. You see? Well, if I tell you that they have inflammation of the right SI, are you going to use heat or ice? You're going to use ice, right? Ice is nice, right? Okay. As one doctor told me, it's like vanilla ice, 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 baby, ice. Okay. All right. Okay. All right. So subjective plus objective equals your assessment, which yields your treatment plan. That right there, folks, that's called medical necessity. You see? And so staff, help your doctor out. Okay. Doctors are stressed. They're always running behind. What can be done? All right. Get those pain levels and everything else that you can. Okay. Now, saying that, you'll see when we start to look at the guidelines, it's like, that makes sense. No wonder. Okay. So here we go. Okay. So number one, it's medical decision making or time. Now, you might say time. Do you get paid to read over the medical records? How many minutes you take doing that? Yes. Okay. However, early in February, Medicare, and once Medicare says something, all the other minions, all the other insurances, they go, we're going to do that too. Yes, do it. Okay. The boss says do it. Medicare says if the doctor is solely using time as a method of determining the level of exam, that they will be audited. Not they might, they will be audited. And I got to sit in, because I'm in the carrier advisory committee for Medicare, and they had a chief risk management person there, and she said, if the doctor said that they spent 30 minutes going over all the records of the patient, and we think it could be done in 12, we're going to audit that, and we're going to down code the doctor. So my thought is, this is my opinion, but this is my thought. My thought is, they can always say, you need to move faster, right? Isn't that what, you're probably thinking about your doctor too, right? Okay. But it's kind of like, they don't need to be in the room for 30 minutes. They could do it in 15. But you're going to have to itemize time. But you know what? If you're thinking about it and considering, this patient is pregnant, this patient might have preeclampsia, this patient may have edema in the feet, she's gone through a C-section in the past, and maybe now she'll have a C. And all this here is like, how are you going to alter the care? That's medical decision making. But you got to document your thoughts. And so here on our list that I've been having you form, document your thoughts. Write it down, okay? Highly, highly important here. So I would kind of guide you, push you over, go to medical decision making, not time. It's like, no, you don't want to go there, okay? There's a trap door there, okay? So there. So as I said, say goodbye, bye-bye to 99201. Take it out of your computer completely, okay? All right? And the reason why is because it's not made for doctors anyway, and it's basically the medical decision making is the same as a level 2, so doctors always, except for chiropractors, are charging a level 2, right? Okay? So medically appropriate, all right? It's going to be medical decision making or time, typically medical decision making, the amount of consultation, the amount of exam. You do what's medically appropriate, but you're not measured on those things any longer. Okay? Yeah, you gotta do everything to support the treatment you're giving. And so do those orthopedic and neurologic tests, because you don't want to say medical necessity was not shown. And so therefore, and it's everything that the doctor does on the day of the encounter. And this is right here. You see this? I put it in blue, if you can tell that. You are paid to think. medical decision making for that doctor. Okay. All right. Okay. So we've been talking about it. Let's talk about it more. Okay. Medical decision making. So medical decision making is defined as the process of establishing a diagnosis. Okay. Assessing the status of a patient's condition, and or selecting a management option like, should I go there or should I do this instead? And it could be, should I use activator or flexion distraction or osseous manipulation, whatever technique, you see? And, the doctor writes down the rationale of why they did that. Okay. So when we look at medical decision making, here's the levels of medical decision making that you will see in that table on the right. On the right, a level 2 is straightforward. Keep that in mind here. Okay. It's straightforward. Level 3 is low medical decision making. It's like not that big of a deal. A level 4 now is moderate, and high is a level 5. Chiropractors, we typically, I would say, in my opinion, I never use a level 5. I can't think of ever using a level 5 exam, either new or established, or a level 1. It's my wheelhouse is level 2, 3, or 4. And keep in mind, when I say level, that it ends in a 3, 4, 5, or 2, 3, 4 for level 2, 3, 4. But it could be a new patient or an established patient. Okay. So medical decision making, that's the stuff. It's kind of like, what? I get paid to breathe? Yeah. I mean, doctors, we get paid to think with medical decision making, but you got to write it down. Okay. What are your thought patterns here? So this is really an important slide. If you want to take your phone, take a picture of this here. This is it, folks. Medical decision making. So the new guideline says medical decision making, number 1, the number and complexity of the problems that you are addressing. Okay. In other words, it doesn't even have to be treating, it's addressing. In other words, if a patient has SI problems, why is their SI joint so unstable? Well, maybe they have a bad knee and are considering a knee replacement. Maybe they have hyperpronation syndrome, a flat foot. Okay. Maybe they're, 100 pounds overweight, or maybe all of those things, right? And so that's, even though I'm considering or addressing their knee DJD, degenerative joint disease here, I may not necessarily be treating it, but it's whatever the number and complexity of the problems, how complex the case is, okay? And then the data. Okay, what data did you look at? Now, you see here, if the doctor is looking at those past x-ray reports there, even if it's negative, the doctor should say, I reviewed, x-rays taken at St. Mario's Hospital, okay? And so then the doctor will say x-rays had no pathology, but the patient had a reversal of the cervical lordosis, all right? Something like that. And then the risk. All right. Now, most of our patients will have a lower risk. I mean, in other words, are they going to die at our hands? Hopefully not, right? Are they going to die from the exam? Hopefully not. I don't think so. But once in a while, you're going to get this here where, the doctor, like, let's say if they have a herniated disc, okay? If you don't treat them fine, don't treat them right, then they might end up in surgery. Okay. Or could it be something else like a tumor? Their headaches, is it from the neck, or it could be a tumor, or because they hit their head in a fall? Those are the risks of, complications or morbidity, which means, either something happening due to the treatment, or you don't want to kill them because of the treatment. Example, patient was referred to me by an oncologist with bone cancer. Can I even treat a patient with bone cancer? Now, you might be saying no. Some of you, well, I don't know. That's medical decision making. So I talked to the oncologist, talked to the nurse, got all those reports there and read through them and documented here. I did treat the patient because the bone cancer was not in the spine. Treated her twice. Okay. She had 8 months of daily headaches. I adjusted her. She started crying like a crocodile. And I thought, oh my God, just remember my name is George. I mean, something else, right? And I said, what's the matter? And she goes, this is the first time I haven't had a headache. Okay. So that's what we do. But it's like, I call it pucker factor here. It's like that's a high degree of complexity. Okay. So hopefully you appreciate my humor here. But the key is we understand that it's kind of like, oh, this is not my normal case. Well, if it's not your normal case, the level of risk is much higher. Okay. And so, those data, what tests, each unique test that you ordered, give rationale that you received from the hospital or another physician. Did you look at, interpretation of those x-rays, x-ray report, the lab report, and then looked at how did that affect your decision making? Discussion of management. All right, I'm going to do this here. I'd like to do rehab on the patient, but the patient has preeclampsia, something, okay? And so we're going to hold off on that till they become more stable, or if they're on restrictions, whatever, okay? And so those are the things. Now, I know I'm overloading you here, but right now, doctors should understand if you look at somebody's medical records or their imaging reports, or even their imaging reports and the x-rays, okay, then write it down that you did it, number one, but then write down what did it tell you. That's medical decision making, okay? And examples of that, like I review the x-rays. The one I like is I independently review the x-rays taken from St. Mario's Hospital and brought in by the patient, whatever, okay? All right, so here's a table. Now let's look at these tables. Now, number one, what I told you here is number and complexity of the problems, remember? Then I said the amount and complexity of the data to be reviewed and analyzed, and then the risk. So out of there, what level do you have, or does the doctor has met, okay? So examples would be, if I met a level 3 here and a level 3 for the amount in data, it's 2 out of the 3 elements. You see that? 2 out of the 3. And I met that. And the lowest common denominator of the 2 was a level 3. So then it's a level 3 exam. Okay. So keep that in mind. Now, doctors, when they're confused, if you're listening, if you're a doctor, if you're confused, or staff, it's like, look at that, look up here, and I don't know if you can see my cursor, but where it says minimal, one self-limited or minor problem. My back's kind of achy. I really didn't hurt myself, but I might have slept wrong. That's a level 2 exam. But doctors, staff, do you ever get a patient that has neck and back problems? Sure. Well, here it is, in the low. Okay, that's like, it's not that significant here. 2 or more self-limiting problems, or they have a stable chronic condition like degenerative disc disease. Don't you see that? That's a level 3. After studying this here, and I go through many case examples in my book, okay? And if you have the book, everything's right there. But the key is we do like level 3s all the time. All right. But now when we look at, a level 4, look at this level 4. Okay. This is like a 99204 and 99214. Okay. And just look under number and complexity of the problems. 1 or more chronic illnesses. Okay. 2 or more stable chronic illnesses, or 1 undiagnosed new problem. Okay, an acute illness with systemic symptoms. Acute illness would be lower back pain, and they also have constipation or urinary difficulty or menstrual dysfunction. Okay, do you ever see that in your office? Yeah, you bet. Okay, now, so that category right there, in this patient, we were able to justify a level 4 exam. Now, let's look at the amount of data. And now here it's the category, or, it's 1, and I would put in there and or. So Review of external notes. Did you do that, doctor? Just do a checklist by this here. Did you independently look at any x-rays or lab reports? Yes. Okay. Did you talk to the family? Well, we do that in a report of findings. Did you do the reported findings the same day? Then that would count for it. You see? I would tell you, you're not going to be doing a level 4 exam on everybody, but I bet you were not doing it on enough people. But it's got to be documented there, okay? And so, just get used to that. And again, in my book, I give you other examples, but we'll do it here too. So again, 2 out of the 3, if you're meeting 2 out of 3 of level 4, then you're probably justified. But then your diagnosis can't be a lumbalgia, right? Or it can't be cervicalgia, all right? Okay. And then the risk, again, how many problems do you have of risk? And the procedures here, we've gone through that already. And then, of course, what are you going to order for that patient? We don't do bed rest, but are you going to do K-tape? Okay, strapping. Are you going to do, down here? I don't know if I have this. No, I wasn't able to bring that. But down here would be like supplements, vitamins and supplements, proteolytic enzymes. How about physical therapy, rehab, orthotics, foot levelers, orthotics, okay? So those are the kind of things that you want to document, and then that gives you a higher level of risk. So these tables here, typically, I think most of your patients are going to fall in a level 3 or level 4. Now, a child may be a level 2, but, you could have a teen, let's say a 11-year-old with a huge scoliosis. Now it might be a level 4, you see? So everything has to make sense. Hopefully you're getting that there. So again, look at this here. Okay, the doctor has a patient come in, low back pain, SI pain, hyperpronation syndrome, which is affecting the Q angle kinetic chain, and has a history. X-rays show lumbar DDD. Well, here we have 2 or more self-limiting problems, 1 chronic illness, and take that picture there, number, complexity. Now that's at least a level 3, you see, based on this here. Okay, so write down the problems and the data that you reviewed, and if any risks are available. The problems, number of complexity, and the data are probably up there. Risk may not be that high in your typical patient, but it's 2 out of the 3, you see? And don't, conflate, don't exaggerate what the patient has. It's just like if you do, doctors, if you have do you get paid for doing a scan of the patient's feet? Yes, because I am ordering that scan, me, the doctor, on their feet. I'm analyzing the data in there and then applying that. And so, yes, that's part of your exam. Do it on the exam day, as long as there's rationale for it, you see? It's stuff we do all the time that you just don't think about here, okay? And it's like the diagnostic procedures ordered, examination, x-ray, lab work, and of course, the kiosk scan, okay? And so, again, medical decision-making documentation. Here's a nice little checklist I gave you here. The exam findings. Did the doctor order a kiosk scan or x-rays or anything else, lab work? Interpretation of tests that the patient brought in and or that were ordered and done on that day in the office. And then discussion with the patient, okay? I gave an example, what type of orthotics. That would go into the medical decision-making, the rationale, okay? Now, hopefully you got an idea there. Doctor, what did you think about your thinking process? Write it down. What did you choose? Why did you choose it? What did you not choose to do, and why? On a pregnant patient, as an example, or an 85-year-old, you may not want to do rehab, right? Or 85-year-old has severe osteoporosis. That's a risk factor. And so now you're going to decide to do, activator. Now, time, time is there. Okay. When would you want to use time? Well, what if mom brings in, or dad, brings in that, from Dr. Google, all that stuff that they downloaded and wants to discuss it with you, in the consultation. Now it's going to take a little longer. Time may be the overriding factor here. Okay. Again, very rare. There are exceptions, but it's rare. Okay. And so, as I stated earlier, the documentation of the time should be exact. Do you want to itemize it? Everybody that not just my opinion. I'll let you know when it's my opinion. Okay. But, in the business here, everything is coming out, and Medicare said it first. We're going to itemize your time here. And it doesn't include what the staff does. The staff does it to save time for the doctor. But if the doctor's using medical decision making, in other words, a doctor who's been in practice for 40 years, who does things quicker, should not be penalized because he or she is efficient, right? So don't use time. I mean, I think that's pretty simple there. Some of the difference, time-wise, but you know what? You could do this for medical decision making too. Is like a checklist, and just to show you, like if you have my book on page 60, there's these E&M inventory tools, and I have checklists and tables in there that I've been showing you here today. But you can go through and copy that page and use that as like a checklist. What did you do today? And make sure it's in the documentation. Reviewing of the test, reviewing separately obtained history. That would be from another doctor or a family member. Okay. Examination. Yeah, it's the time there. But again, did you take too much time? Counseling, ordering supplements, tests, or whatever it might be. Okay. Referring the patient out to a neurosurgeon. Document it. But again, you can see it could be medical decision making too. But I don't personally, this is my opinion now, I don't want some Yahoo reviewer telling me, well, that should have taken 12 minutes, not 30. It's like, you weren't there. But medical decision making, if I write down what I'm faced with here, I don't believe they can argue it. And if they deny it, then call me and I'll be happy to help you out with a rebuttal. Okay. All right. So the key is, the time is everything that's done on the day of the encounter by the doctor, not staff. Okay. And so, time for new patient is in increments here of about 15 minutes and, 10 minutes for an established patient here. So are you really going to carry around a stopwatch and time yourself? No. Okay. I mean, you've got patients, you're busy here, okay? But write down what you did. And so tell your doctor, if you're staff here and helping your doctor out, write down your rationale for doing everything. Okay, what was ordered? Why? What was ordered? Why? Okay? And you could even say what was ordered, and if not, what was considered? What was considered? Why not? Okay? Because of, like an MRI. I'm going to order an MRI on the patient. Oh, the patient is claustrophobic. Okay, I'm going to order an open MRI. You see? Well, that's my medical decision making. All right, hopefully that makes sense there. Okay, so again, this here in the meetings I was in, I spent an hour on the phone after a patient's appointment is not sufficient. What did you talk about and why? Yeah, when I heard this, it's like, oh my gosh, I could just see an opening. It's like, oh yeah, here, let's go ahead and deny this, right? Okay. And so it's always got to be medically necessary time, and you're not going to be doing prolonged service of time anyway. Okay. So again, here is I know it's towards the end of our time here, but this is prime right here. What problems or conditions is the doctor managing? Communicate those complexity of the conditions, severe osteoporosis, demineralization, whatever it might be. Okay. The patient had 10 out of 10 pain and had to be helped on and off the table even. Okay. Document a clear assessment, treatment plan, their diagnosis here, okay? All right. Again, the diagnosis, here's the diagnosis book, okay? You can buy the bundle and get I'll give you a promo code here, but it's not just selling that. I speak to chiropractors because I've been one for, over half of my life here, okay? But in your interpretation, what did you find out through the tests? What did you find out through the examination? What did you talk to the patient and the family about? What did you all, patient, family, and the doctor, decide to do or not decide to do? And that, whatever, just do a clinically, medically appropriate history and exam. So talk to the doctor, because we're in 2021 guidelines now. Do a gap analysis. It's like, what did I talk about that the doctor's not documenting now? It's like, you got to do it. Okay. Time to get out that cattle prod, right? Okay. Review the guidelines, fill in those gaps here. If you need help, I'm available. You can send me an email. I do personal coaching as well. But, your electronic health records, if you have it, put in the appropriate macros. I had a doctor call me up and just wanted me to go over macros for her EHR. Okay, we did that, and she was so happy because that's what I do. And I don't even have to think about it. I don't need a PowerPoint slide because that's my life, okay? So update your education. If I'm coming live, go to a live class, okay? And, ChiroHealthUSA will have me on the road here, as well as Foot Lovers, NCMIC. But, if you want, an ear like Mario, if something happens, tell me. The way you do it, facebook.com/askmario, and like me, put me in your notifications, and I'll be there to help you. Okay. So our books, if you're wish to purchase them, you can do this book here is the coding book. It's brand new. It's 4 weeks old now. Our 2021 guidebook there. I have a combo too, and if you order the combo of books, ICD-10, if you use the promo code save now in capital letters at askmario.com, and we're actually going to go today and we'll mail those out for you folks here. But for ChiroHealthUSA attendees, use Save Now, you get free shipping. They just raised rates again, $15 to ship this year, but we'll do it for you for no charge, plus take $10 off the book, okay? All right, Christy, I think I made it. So if there's any questions here, but again, my email is at the bottom of the screen there, doc@askmario.com. If you wish to ask any questions, if we don't get to it, I'll try to answer, and I'll take as much time as you need there, Christy. Okay, go ahead.
Okay. Would you bill an E&M code for an exacerbation after a patient re-injured themselves doing something else? Or is that assessment just built into the CMT code?
Okay, great question. Whoever said that, high five yourself, okay? If it was an exacerbation of enough importance that I am changing their treatment plan, I am going to do an exam, yes. Okay. Now that's just, it depends clinically appropriate here, but an exacerbation versus an aggravation. I'm just kind of sore because I played pickleball. Okay. I don't need an exam. Okay. Because don't forget, we do a mini exam when we do the manipulation. But if the patient goes, I was playing pickleball and I did a header and I came down on my shoulder and I can't even move that thing now and my pelvis is killing me, I'm going to do an exam and you charge for it. Yes.
Okay. The next question, since insurance will not reimburse for an E&M, do you bill it to the patient?
Yes. Period. Now we put them on ChiroHealthUSA so they get a CHUSA discount, if you will, but you know what? We do it. I've never had a medical, let's talk, real here. I've never had an MD say, well, I'll check on your insurance and see if it's covered. This is what's medically appropriate, and especially an exam.
Do you think it's acceptable to have your staff administer a functional outcome assessment and charge for a 99211?
In my opinion, no, it's not appropriate. That code is not, because it's just, I know there's doctors that do it. there's actually a charge, which is not that code, for administering psychological tests. And on audit, they're always being denied. It's just part of the paperwork. But now, listen to me, whoever asked that question. When the doctor considers the information in those functional capacity test questionnaires, that's medical decision making. Now, yeah, you charge for it. You see, you don't have to charge for filling out a form. The patient does it. It's the doctor to analyze it. That is part of the exam. And remember, when are you going to do those type of forms? Typically, exam and re-exam.
Let's see. Okay. You said it was mandatory to have two things. One was the HIPAA manual. What was the second one?
Corporate compliance manual. That happens to do with the Patient Protection Affordable Care Act of March 23rd, 2000, mandated that you have a compliance program, which is corporate compliance program. If you need help with that, send me an email, but I'm certified in it. I've been a certified instructor for years, and I think we're in our 11th edition. Okay, and the book takes you step by step. Each chapter, you fill in the blanks, and forms are online and stuff like that. They'll take you through it. Okay, it's just you got to have it. Period. Okay.
Let's see the next question. Time of service discounts are tricky. Are you saying our office cannot offer a discount over 15%? We currently offer 20%.
That's a good question for Christy. Okay, but Christy, you can chime in here. The government, in a 2009 advisory opinion, said anything over 15% may be construed as being an inducement. Okay, so time of service. Now, there are some states that say no more than 5%. So, right, Christy?
There are also some states that say 30, but federal guidelines say within 5 to 15%. The thing about a time of service discount is that it needs to accurately reflect the bookkeeping savings by not having to bill the patient afterward. And I've heard multiple consultants say that for chiropractic, it's actually only about 8%. Yeah. So a 20% discount might be, but it really just depends on what you're actually saving. And so that's going to involve a whole lot of math and probably the help of your CPA.
If I can add, just think of it this way, okay? This is my opinion, Christy, if you have anything to add. A time of service discount is a discount for administrative time of filing a claim. You don't have to do it. A cash discount, that discount is CHUSA. Okay, it's like cash insurance. Now, I'm not filing a claim, but also I'm giving you a break on managed care because you're a cash patient. Okay, in other words, your insurance has a really high deductible. You're not going to be using your insurance. Okay, right, Christy?
Yes.
Okay.
This one, I says, I appreciate Dr.
Let me just say, your cash patients, okay, do you want to give them a discount? Well, you're not giving them a discount because you don't have to file a claim. You're giving them a discount because they're cash. That's where ChiroHealth, believe me, patients love CHUSA. They just love it.
And I did see that somebody asked, how do you get your patients on board with CHUSA? It's actually really, really easy. And it really has to do with exactly how you present it to them. The biggest mistake most clinics make or staff makes is that they never tell the patient what the actual cost of services are in the practice, which I think is a huge mistake. They need to know the true value of the services that you provide, which kind of rolls into this next question that says, I appreciate Dr. Mario stating that we are not responsible for the patient insurance. However, it's all over the patient's EOB that the patient is not responsible and they always refuse to pay.
Well, number one, okay, in Medicare, if you use a GA modifier, or in the case of therapy, GP, GY, or exam would be GY, then it will come, the EOB will come back and say that the patient is responsible for it. Number two is any other PPO, Blue Cross, or any other commercial insurance says that non-covered services do not have to be filed with the carrier if the patient agrees in writing ahead of time that they will pay cash.
Okay, next question. Somebody just wanted to say that they didn't see the 2-book bundle on your website.
Well, it's on there. It's the there's a bundle for the compliance manuals, and then these 2 books. It's on the website. Okay.
I see them individually, but I don't see them on here either as a bundle.
It's on there, but even if you order one and order the other and then put in the promo code, it still gives you the discount. Okay.
We bill a 99203 usually for a new patient in our office. If the patient came back in, like you said, at 2 years and 11 months, can you not bill a 99203 even if it is a very complex issue?
Yeah, correct. It's a 99213. But if it's a very complex issue, it's a new problem, it might be a level 4 exam. That's just the rules. Okay. What insurance? No, that's CPT guidelines, period. Everyone follows them. Everyone has to follow them.
Let's see. Does a time of service discount have to be given at the time, or can it be applied within 2 weeks to give audit of changes? Well, the whole premise of time of service is that it is given at the time of service. So once you give a discount past that, after they leave, if it's not given, then now you're just giving a discount for the sake of giving a discount. And then you are starting to muck up the waters of what's appropriate. Wouldn't you say, Dr. Mario?
I agree.
I love it when that happens.
If you have questions, I mean, let me just tell you, I know these kind of questions, number one, and I'm in Arizona, they're in Mississippi. Anytime we have questions in our office, we call them. Okay. They know their stuff. Now, if you have other questions, you can send me an email too. But I always tell doctors and staff, the first adjustment that you have to make is always between your ears. Okay. Because it's kind of like, oh, I'm not worthy. Okay. Yes, you are. You charge for the services you do. I charge a fair rate. I do what's medically necessary, and you pay me. Okay. And some of you don't remember Petticoat Junction, but it used to be Sam Drucker was the grocer, and people would go to the grocery store and say, just put it on my tab, Sam. And they did that. Okay. We're in the new decade. All right. You go to Walmart, you put I don't have enough money. I can't pay for that. You don't get it. They don't give it. Well, I'll give you, 2 dozen eggs for 1 pack of bacon, whatever. I mean, it's just charge a normal rate here. But the thing is, extend a discount out of the goodness of your heart. That's what ChiroHealthUSA does. Okay. And they will help you.
Yeah, there are some strong rules that govern the types of discounts and how big of that discount out there. And ChiroHealthUSA just makes it really easy and simple for you and your team to be able to give those discounts without exposing yourself to unnecessary risks. So we have one person who asked the question that says, do you have your Medicare patients sign an ABN? Well, there's not a lot of info there, but I would say yes, but there are certain criteria for when they should sign that ABN form. Dr. Mario, can you share that with us?
Well, an ABN form for manipulation is signed whenever they go from AT to GA. Okay. I always say GA is Wellness World, and to get there, you need a passport. That's the ABN. But the non-covered services, we know there are services that are non-covered always in Medicare, and then a patient can sign an ABN type form. In my Medicare classes, I teach you can use an alternate form. You don't have to use the ABN for non-covered services, and that could be signed on day 1. And remember, those ABN forms are good for up to 1 year.
I always, when people ask me this at conventions, every time I speak, it doesn't matter what I talk about. The ABN always comes up, what to do for non-covered services. And
ABN, look at it as a passport. If you're going from AT to GA, to go to GA world, you need a passport. Okay, sign the ABN, now you go. Now, if you come back into AT, because of a exacerbation, you're AT. When you go back into GA, now you sign another ABN. That's all it is.
I love that.
Can I add really quick?
Yeah.
A lot of Part C Medicare check on their benefits, because now, as of January 1st, 2020, Medicare Part C can, depending on their plan, now start to pay for therapy and exam. Always on Part C, always check on their benefits, okay, for Part C.
I love that. And I was going to say, for all of those non-covered services, have a price sheet that just lists out these services. These are services not covered by Medicare, and you can put the price range for exams and therapies and things like that, and just have them sign that they understand that those services are going to have to be paid out of pocket. And then you don't have to worry about it. So we're using the ABN only when we're not covering adjustments when you have discharged them from care and they go to maintenance. Or as Dr. Mario said, now I'm going to say this, you just watch my next class. It's the passport to get from the AT to the GA. I love that so much.
Wellness world. Yep. The Garden of Eden. It's the wellness world. Okay.
Right. And so I don't see any additional questions there. Again, I want to encourage you that if you have questions, to reach out to Dr. Mario at doc@askmario.com. And again, I just want to reassure everybody, a lot of you know, because you've been hanging on to these webinar series for years with us, and you know that if you have questions about anything, you can reach out to ChiroHealthUSA at info@ChiroHealthUSA.com, or calling our 800 number at 888-719-9990. We joke all the time that about 90% of the phone calls and email inquiries that we get don't come from our contracted providers. They don't come from people who are doing business with us. They just simply have a question about their practice and need help, and we direct them to the amazing panel of experts like Dr. Mario that we work with on a regular basis. So if you have a question that you need an answer to, let us know, and we'll connect you with the right consultant, or we'll give you the answer and let you know which consultant gave us that great information in case you need additional help. And so don't hesitate to reach out to us if you have any questions. Thank y'all so much for hanging in here. We went a little bit over, but you know what? That's because Dr. Mario is the man, and people always have lots of amazing questions from him, and you guys did not disappoint today. So we have a lot of great webinars coming up, and we're adding more and more. Y'all are going to have to forgive me, because normally I put them up like 4 and 5 months in advance. And that has not been the case in 2021. So next week we have Dr. Evan Gwilliam, who is creeping on this webinar right now. Hey, I'm just kidding, Evan. But he's going to be here talking about where did my G codes go, because that's been coming up in a lot of webinars lately. We're going to talk about intro to occupational medicine for chiropractors the following week, and then how to white label nutrition in your practice. So we have some really exciting topics coming up for April that we're going to be posting on the website really soon. So stay tuned for that. Make sure you go to our website at ChiroHealthUSA.com /webinars. It's also at the very top of the screen. And you can see all of the upcoming webinars. Click on the right-hand side of the screen under Visit the Archive, and you can see all of the webinars that Dr. Mario has done with us in the past. Oh, and Evan, you prefer lurking to creeping. I'm just kidding. Dr. Mario and I love hanging out with you anytime, even when we can't see you. And then for somebody who just asked, what was that phone number again, Vanessa, I just posted it in the chat box for you. I just want to thank everybody for being here today and spending your time with us, because we know how valuable it is. Have an amazing rest of your day and a fabulous week, and we will see y'all next week. Bye.
Thanks, Christy. Bye-bye.